Welcome. Today I'm going to be talking about developing and executing stakeholder-engaged rehabilitation research. I have 5 objectives for my talk today. And by the end of this talk, I would like you to be able to understand the potential of stakeholder engagement in improving healthcare quality, be able to define stakeholders, to articulate the role, rationale, and responsibilities for stakeholder engagement in research, to describe the principles of stakeholder engagement, and to identify opportunities for stakeholder engagement in your rehabilitation research. Let's go into a little bit of background first. We know the broader context in which we as rehab researchers are engaging in. We know that there's a need to accelerate the evidence to practice gap. There's a need to enhance healthcare quality, and we need to mitigate healthcare disparities within the healthcare system. So when we think about the challenges to delivering efficient, high quality care, we are challenged with this 17-year evidence to practice gap. And even for the evidence that does get to the clinic, in fact, it's only 14% of research that makes it there. The seminal National Academy of Medicine, previously known as the Institute of Medicine, has put out 3 seminal reports which have documented a fundamental need for system change to address quality and the need to address the complex sources of healthcare disparities that are rooted in historic and contemporary inequities. So given these challenges, I suggest that stakeholder engagement is a solution to these challenges. When we as researchers think about the rehab research and research that has been done more broadly, we need to recognize the history of mistrust among communities of color when it comes to research, and recognize the limited considerations of the real world context, all of which is contributing to the 17-year evidence to practice gap. And finally, the voice of the lived experience is often absent from the development and implementation of research. Learning health systems are one strategy that provide an opportunity to address some of these challenges. The goal of a learning health system is to create knowledge as a byproduct of the patient-clinician interaction. And this is achieved through a system that integrates research, data science, quality improvement, and stakeholder perspectives. And this is achieved by engaging patients, families, and other key stakeholders in learning health system activities. And this requires their perspectives to be integrated through governance, direct care, and quality improvement initiatives, and policymaking, so that our stakeholders are represented at every part of the system. So who are stakeholders? There are multiple definitions out there that operationalize the concept of stakeholders. PCORI operationalizes stakeholders as patients and other stakeholders. I like to use Concannon's 2012 definition, which Concannon and authors talk about the 7 Ps. And the 7 Ps represent each of the different stakeholder groups: patients and public, providers, purchasers, payers, policymakers, product makers, and principal investigators. And in Concannon's model, it's this group that collectively works together to achieve the goal of addressing a clinical dilemma. So how is this achieved? What are the roles, rationales, and responsibilities for stakeholders in research? Building on PCORI's model, a cyclical model, patients and other stakeholders are able to help determine research partnerships and capacity through building relationships and patient-centered outcome research skill building, informing research priorities through topic solicitation, input, advisory panels, and workshops. They can help engage in the conduct of research as part of a research team. They can also support dissemination and implementation through the sharing and uptake of findings. And finally, according to PCORI, they can inform policy and practice by engaging in the impacting of institutional policies and clinical practice, all of which can then feedback into the cycle and inform the next cycle of research and partnership capacity as an ongoing cycle. When we think about an individual stakeholder, we need to think about their role. And stakeholder engagement has been talked about as a continuum. You can have stakeholders that provide input, maybe as a one-time activity, all the way up to a collaboration in which they are embedded in the team and working to achieve the research goals. And in the middle, then you have consultation. And it is this continuum that we can think about as rehab researchers as we are designing our studies and thinking about how to best meet the needs of our study with the stakeholders that we are collaborating with. Carmen and authors in their 2013 Health Affairs study, they actually integrated the concepts of the learning health system engagement with the continuum of stakeholders and presented a nice grid that presents how we think about the level of engagement in terms of direct care, organizational design and governance, and policy making based on the level of engagement for consultation, involvement, partnership, and shared leadership. This will be a nice resource as you are starting to think about and operationalize the engagement that you will be capitalizing on for your work. Concannon in 2014 used a similar structure, but applied it to a clinical dilemma for and addressing engaging stakeholders in the research process. And while this is a cyclical process, I have laid it out in a linear manner just for ease of readability, but highlighting the link back to the beginning as a way to convey this cyclical nature of this process. And according to Concannon, this group talks about stakeholders being engaged at evidence prioritization, evidence generation, synthesis, integration, dissemination, and application, and then feedback and assessment. And we are going to dive into each of those in a little bit more detail in a few minutes. So why engage stakeholders at each of these stages when we think about Concannon's framework? Engagement with stakeholders can foster early buy-in of your research. It can foster successful program or intervention, design and implementation, and support sustainability. Because the end goal of your work is to establish meaningful stakeholder-driven solutions that don't take 17 years to get to the client. So how do stakeholders contribute? This is a question I get asked quite a bit. These individuals bring their own life experiences as well as whatever their daily job is. All of these experiences come to the table and they bring those perspectives as you are engaging in research. So these diverse perspectives can highlight perspectives of a targeted community or population, if you have representation from the community that you are trying to work with. It also increases opportunities for researchers to be more aware of community concerns, barriers, and opportunities that we as researchers may not be aware of because we do not live in that community or may not be affiliated or identify as a member of that community. Further, meaningful research community collaborations provide opportunities to advance social capital within a community and increase researcher credibility. Given our prior discussion of mistrust, particularly among communities of color, using and capitalizing on meaningful stakeholder engagement over a duration of time can help to address those barriers and build trust, therefore advancing social capital and credibility. So what are the guiding principles of stakeholder engagement? First, there are 4 principles: reciprocal relationships, co-learning, partnerships, and then transparency, honesty, and trust. What is reciprocal relationships? This means that there are clearly defined roles for all involved parties. Shared decision-making authority is addressed, and it clearly identifies and articulates how shared decision-making is conducted between researchers, patients, caregivers, and other stakeholder groups. Co-learning. You want to champion collaboration, but what this means is that for stakeholders, you want them to understand the research process. You as a researcher are not there to foster their development into a principal investigator who's going to lead research. They just need to understand the foundation so they can provide meaningful feedback that meets your needs as a researcher. And as researchers, it is our goal to become experts in patient learning and stakeholder experiences. Each of us come to the table with our own experiences and expertise. As the PIs, as the investigators, we come with the science understanding, but they come as the experts of the lived experiences of the lives and the communities in which they live, both of which are important. And partnerships. The time and contribution of all stakeholders needs to be valued in a meaningful stakeholder engaged partnership. This means fair financial compensation across all stakeholders and reasonable and thoughtful requests for time commitments. So how do we think about that? When we think about meaningful funded roles, we're gonna think back to that continuum of research. How are we reimbursing our stakeholders for their time? They are bringing their expertise to our table in which we are together meeting a research need. So they must be compensated for that contribution. They're bringing their expertise. So thinking about funding our stakeholders, whether it's as an advisory committee member, a consultant, an investigator, each of these should be remunerated because they are bringing their lived experiences. So when we think about these partnerships, the research team needs to be committed to stakeholder representation. And this should be considered across all project activities. We need to think about, as particularly principal investigators, how do we establish a climate of cultural competency, particularly if we have some investigators that maybe haven't engaged in stakeholder engagement in the past. How do we ensure an environment that is safe and welcoming for our stakeholders once we start collaborating? And that's where it comes to establishing an environment for participation, not just in terms of cultural competency and a welcoming environment, but also identifying barriers to participation and ensuring access to necessary accommodations. And this is where each of you as investigators need to think about the specific needs of your stakeholders. Do you have individuals who may have mobility issues? Are you going to hold in-person meetings? Are there barriers for an individual to get into the building? Are there transportation challenges? Are you working virtually, particularly in this COVID world? And you may be collaborating with some communities that may be housing insecure, may not have Wi-Fi, may be challenged in the actual connecting to a virtual meeting. So it is your responsibility as the investigator to identify those barriers and come up with strategies so that they can participate in the most meaningful way. And finally, trust, honesty, and transparency. This is where, as the investigators, you need to think about the shared communication. How is information going to be readily shared with all research partners? How is there going to be clarification about open and honest communication with each other? And as decisions are made, what is the governance structure to support inclusive decision-making? So given those principles, I would like to walk you through an example. So I'm going to walk you through an example using Concannon structure from 2014 and give you an example from one of our PCORI funded studies. So our question, what is the right care to the right patient at the right time in long-term care, in particular for residents with dementia? So I'm going to walk you through our engagement process, starting at the pre-proposal development phase. At this point, a few years ago, we engaged in dialogue and discussions with system leaders, families, frontline providers to understand what was the priority clinical dilemma. We also went to the literature to capture perspectives of policymakers and payers and providers more broadly, as well as patient advocates. So we made sure that we had a broad understanding of the variety of clinical dilemmas impacting the care of residents with dementia. So whose voices did we capture? We captured, I would say, every of the 7 Ps except product makers in our examination of dementia care in nursing homes. When we sought their perspectives, we wanted to hear their clinical dilemmas, and we wanted them to prioritize, once we identified the clinical dilemmas, the interventions that we needed to consider as our comparators in this pragmatic clinical trial. And we also wanted them to tell us what their primary outcomes, as well as secondary outcomes that we needed to consider. And I will say that the certified nursing assistants that we engaged with came up with some of the most insightful recommendations for identifying secondary outcomes that we as researchers would never have thought of. So this is where stakeholder engagement is so meaningful. That boots on the ground, frontline provider perspective has much more experience and that lived experience that just enriches the studies. Our stakeholders, through this feedback, helped us identify the scope of the project and the design of the pragmatic clinical trial, how to randomize, how to train facilities. They had their hands in feedback to every aspect of this proposal development. And oh, by the way, they helped us write the grant. Our team is made up of clinicians and individuals from the research community. It was an iterative writing process with our stakeholders, and it made for a much better product. So how have we been working to generate the evidence in this clinical trial? We did set up a collaborative stakeholder engagement model. In fact, our organizational structure is established where we have the academic researchers, a 19-member stakeholder advisory committee, and a clinical community, all within the research study team. And this is a multi-PI project. So I am one PI, and my co-PI is a member of the clinical community. So we work together to execute every aspect of the study with ongoing feedback and engagement from our stakeholder advisory committee that we meet with monthly. We established a governance for shared decision-making, power across all 3 of these groups. And there's a responsibility of when we get feedback, we have to provide, we need to follow up and say how we addressed any decisions that were implemented. So who is on our team? We have a variety of community experts, from informal caregivers, patient advocates, to frontline staff, health system leaders, policy leaders. And then we have a series of academic experts with a variety of expertise, from dementia care, health services and implementation science, all the way to economics and stakeholder engagement methods. All of these perspectives are brought to our team. So what's an example of engaging stakeholders in evidence synthesis? One of the activities that we are engaging in at the request of our funder is to develop a survey of informal caregiver perspectives. This required a review of the evidence, which included a scoping review and a systematic review, of which our stakeholders on our advisory committee have been engaged in every step of these 2 reviews. They helped us to develop the questions. They've helped us analyze the data that has come from pulling information from each of the articles, and they are helping us write the manuscripts at this point. They will also be helping us to develop the survey in the next phase of the study. Finally, evidence integration. We're not there yet, but our plan when we get towards the end of the study and have all of this data and can start answering our clinical questions is to have our stakeholder advisory board continue to be actively engaged in all aspects of the evidence integration. We are going to have quantitative data and qualitative data that together we need to integrate to answer our key question around our clinical dilemma. And they will be actively involved in looking at the data that emerges and helping us contextualize and integrate those findings. And finally, dissemination and application. While we're still in the middle of this study, they have already been involved in and helped us develop manuscripts. We have 3 under review right now, and 1 been accepted. They have participated in writing and presenting conference abstracts, and they have also helped us write subsequent grant proposals as topics have emerged relative to COVID and other topics. We have worked with them to develop spin-off grants to address key priorities that they have identified. And finally, feedback and assessment. We seek regular feedback from our advisory committee, actually twice a year. Every August and December, we send out a survey where we have them rate our level of engagement and how well we are engaging them on a series of domains. And we take that feedback and we respond and give them the status of our survey the following month, and where we have fallen short and we need to improve, we present our plan for improvement and they provide us feedback. And this has really helped to foster, again, that transparency and trust. As we think to the future for our study, we also hope to use this feedback and assessment as a way to inform next steps on the next grant and efforts to disseminate and inform practice. So in conclusion, I would suggest that a learning health system intends to decrease 17-year evidence to practice gap, address disparities, and ensure the development of patient-centered care. These goals cannot be achieved without meaningful stakeholder engagement. So to that end, as rehab researchers, we need to think about rehabilitation learning health system research and the value of stakeholder engagement and embedding researchers and championing stakeholders in every aspect of the research process. It's only by integrating their voice and their experiences that we can really achieve the goals of a learning health system. And with that, I thank you and I look forward to discussing your questions with you.